Okay, we are back. Dr. Kious, I'm really happy to see you. So I'm going to go ahead and introduce our next speaker now. He is Dr. Brent Kious. He is a psychiatrist and holds a PhD and is assistant professor of psychiatry at the Huntsman Mental Health Institute in Utah. He's also core faculty in the Center for Health Ethics, Arts, and Humanities at the University of Utah, and adjunct professor in the Department of Philosophy, also at the University of Utah. Thank you very much for being with us.
Thank you so much for having me. And I just want to apologize to the other speakers for the fact that I wasn't able to attend a lot of the talks. I have been balancing clinical obligations upstairs in the hospital, so I've been pretty busy this morning.
Yeah.
I'm going to pull up my slides now. Okay, so today I'm going to talk about some work that we have done with community engagement, designing focus groups really that get the perspectives of individuals who have themselves survived a suicide attempt or family members of persons who were lost to suicide regarding the potential for utilizing genetic testing and especially the development of polygenic risk scores based on direct-to-consumer testing for suicide risk. My co-investigators and I don't have any conflicts of interest that I think are applicable to this. I'm currently funded through the Utah Center for Excellence in Healthy Research, as well as the Greenwell Foundation and CCAH and the State Board of Education in Utah for some research related to suicide prevention. So here is roughly the outline. I will first just talk a little bit in conceptual terms about the possibility of doing genetic testing for suicide risk, which I think is a sort of surprising idea to some. Then I will get into the results of our focus group studies. And if there's time at the end, I will briefly consider some of what I see as the main ethical problems related to utilizing genetic tests for suicide risk, especially if they involve direct-to-consumer genetic tests. One, I think, really important question there is suicide meaningfully different from other kinds of genetic tests for behavioral phenotypes or mental health phenotypes? And I think it might be. A little bit of background. Clearly, thinking about the genetics of suicide matters because suicide is such a problem. Rates are generally increasing, although I see reports that they have fallen off over the last couple of years, at least in certain demographics. Utah is notable for having a very high suicide rate. Often we're the highest in the country, competing with Wyoming, Alaska, many of the other states in the Intermountain West. There's maybe an interesting story to tell about why suicide rates are higher in this part of the country. Really significantly, suicide has been generally the second leading cause of death for younger persons, teens and young adults, especially since about 2019. And all the evidence, I think, now points to the fact that this is only getting worse with the effects of the pandemic on mental health. I think it's also really striking that suicide rates have been increasing fairly steadily overall, despite the fact that we just continue to spend more and more on mental health services. So the red line here shows you per capita expenditure on mental health services adjusted to $1986. And the blue line is suicide rates. So there's some disconnect, I think, between all of the efforts we're putting into suicide prevention and treating mental disorders and the effect that they are actually having. Clearly, we're not getting our money's worth in certain ways. So when we talk about there being a genetic risk for suicide, often the concept is met with skepticism itself. People think, I think quite naturally, this is a behavior that is presumably influenced by all manner of environmental factors, like, say, the accessibility of firearms or lethal medications. How could it possibly have a genetic component? But a number of my colleagues here, especially Hillary Kuhn and Anna Docherty, who are co-authors on the paper I'm discussing today, have done a lot of work looking at the genetics of suicide. If you look at families, and especially in twin studies, it turns out that suicide death has a heritability of about 50%. And they have done a lot of work with families in Utah to actually characterize the genetics of suicide. Utah has a number of advantages for doing this kind of work. First, largely because of the influence of the LDS Church, we have very, very large families with very well documented pedigrees. We also have a state office of the medical examiner that has been keeping record of suicide deaths for a number of decades. And it's possible to bring all of that information together and create pedigrees like the ones you see here. I think it's a little bit fuzzy, but all of the blacked in squares or circles are people, or diamonds, I guess in this case, are people who died of suicide. The red ones are people for whom we had genetics. And if you just look at the top pedigree, I think it's really striking that so many people in that one family died of suicide. You know, if you consider that the overall population risk is probably about 0.1 or 0.2%. Clearly, there's something going on there that is perhaps heritable. In light of those kinds of findings over the last 5 years or so, a number of investigators, including many here at the University of Utah, have conducted genome-wide association studies looking at suicide death, suicide attempt, and suicidal ideation. I'm showing here the Manhattan plot from Dr. Docherty's study of the genome-wide association of suicide death. There are definitely genes or loci that seem to be associated with an increased risk of suicide. It's important to note that most researchers in this field, and I should clarify, I'm not really one of those researchers, I'm an ethicist and a psychiatrist, not a geneticist, think that the phenotypes of suicide death, attempt, and ideation should be treated differently. And in fact, it looks like the genetics are quite different. Many people who have suicidal ideation don't actually make a suicide attempt. And many people who make suicide attempts because of differences in how they attempt don't ultimately die of suicide. One concern that people raise about looking at suicide genetics is it really just the genetics of mental illness, including mental illnesses like major depressive disorder? The upshot of this slide is just that it does seem that suicide death, or suicide attempt in this case, seem to have genetic risk factors that are distinct from those associated with other mental disorders. And if you think about the fact that many suicide decedents, roughly 54%, have no known prior mental health condition, I suggested at least a fraction of them really don't have a DSM-5 diagnosis, but ultimately die of suicide for reasons that aren't related to a mental disorder. So with genome-wide association studies in hand, it is possible, and Dr. Docherty's group and others have actually done this already, to generate polygenic risk scores for individuals that tell about their risk of dying of suicide. And with that possibility, there's really no technological reason that direct-to-consumer genetic testing companies, DTC, GT here, couldn't just leverage those results and produce polygenic risk scores based on the tests that they market to people in this country and others. And my guess is that if commercial entities can do something like that, they probably will. That, I think, raises a number of ethical challenges and reasons to be concerned about the practice, and perhaps suggests the need for regulation or education. It's worth mentioning, and I think Dr. DeVries probably already talked about this, that there are a number of companies that are already utilizing polygenic risk scores to produce reports about someone's genetic risk of developing various mental health conditions or even mental traits. This is one example. Genomewide produces the polygenic risk score, or several scores related to your core genetic mental health capabilities. And we'll talk about things like your predisposition to moodiness or irritability, your predisposition to be a late night eater. Will tell you something about your risk of being a night owl or somebody who wakes up early, and so on. They don't, so far, to my knowledge, say anything about suicide risk. Some companies have already started to apply genetic results to the prediction of suicide. Sundance Diagnostics was a now defunct company that took results from the Max Planck Institute related to genetic risk for developing suicidal ideation in adolescence after an antidepressant had been started, and purported to produce a test that would tell people whether they were at risk of having that phenotype. They've been closed down for several years. As far as I can tell, their website is not currently really operational. Another company, MindX Sciences, has recently started to market a complex multi-part test for the risk of suicidal ideation. They call it the SX Prevent digital test, and it has several components. It collects information from users, from patients on a cell phone using an app, but also involves a genetic sample. They're not currently using polygenic risk scores, but what they call convergent functional genomics and gene expression analysis. So they're looking at a number of very specific markers that have been associated with suicide risk. But the principle is the same. And I should say that test is not actually direct to consumer. It's something that your physician has to order for you. To this point, I found one company that on a direct to consumer basis will tell you your polygenic risk score related to suicide, although it turns out it's a Russian company. And given recent events, I think it's very unlikely that anyone in this country will be doing business with them. But Genotech purports to be able to give you a polygenic risk score for suicidal thoughts or suicidal ideation, as well as numerous other mental health conditions such as bipolar disorder, depression, neuroticism, etc. And most recently, a number of researchers have started or filed a patent for a genetic test that is supposed to predict the risk of suicide. This is, I think, again, not polygenic risk scores, but a number of specific markers. And they claim that it will allow the a priori detection of a risk of suicidal tendencies in people who are not currently exhibiting suicidal ideation or have made suicide attempts, including in healthy subjects. So in light of that commercial background, in light of the technological possibility of developing polygenic risk scores for suicide across several different suicide-related phenotypes, our group really wanted to get a sense of what the impact of those techniques would be on the community. And on a pilot basis, we conducted several focus groups here at the University of Utah just before the pandemic, fortunately, to talk with individuals who had themselves attempted suicide, as well as family members who had lost a loved one to suicide, to get a sense of whether they thought this would be a good idea, whether it would be useful, what ethical concerns they might raise about it. We worked very closely with our community collaboration and engagement team here, which is a part of our Center for Clinical and Translational Sciences at the University of Utah. So we developed an interview with them. Then we recruited a number of participants from our local chapter of NAMI and AFSP. It's probably worth noting that that might change the results of a study like this compared to just recruiting from the community at large, since those are all going to be folks who have a lot of interest in mental health and think about it a lot. They went through a consent process. We ultimately had 3 separate 2-hour studios and then looked at all the results from the transcripts that CCET collected. It was primarily a sample of convenience from our local geographic area. We excluded people who seemed to be at risk of getting dangerously upset through participation. So individuals with active suicidal ideation, who were psychotic, who were intoxicated, or who had made a fairly recent suicide attempt or lost their family member fairly recently within the last 2 years. In the end, we had a total of 31 participants split across those 3 groups. We had 1 group involving suicide attempt survivors, with 11 individuals recruited and 8 actually making it to the session. In the 2 family member groups, we had a total of 13 participants. They were predominantly women. Most of them were between ages of 29 and 75. It was largely a Caucasian sample, which is reflective of the demographics of our local area. And what was a surprise to me turned out to be a largely not religious group of people. So about 60% of them reported no religious faith, and then the rest were largely members of the Church of Jesus Christ of Latter-day Saints, as anticipated. We were worried about how participation in the studios and the focus groups would affect the mood of our participants, and also whether it would worsen suicidal ideation. So we gave them several measures before and after participation. One measure we used was the profile of mood states, which is a way of assessing general psychiatric distress and has validation over very small time scales, such as 2 hours. A higher score is worse. So our participants, and this is just the survivor ratings now, actually seem to be a little bit more moody and a little bit more upset prior to participation than they were afterwards, although that wasn't ultimately a significant difference. It should also be noted that 2 participants, 1 in the survivor group and 1 in the family groups, reported very significant distress after the studios to one of our mental health clinicians who was present, and they were triaged to appropriate services. It turned out that they weren't necessarily upset because of what happened in the studio, but had pre-existing symptoms that were quite considerable, and they slipped through our exclusion criteria. So here's what we asked our participants. First, we asked, what does the idea of genetic risk for suicide mean to you? That question was initially intended to get at the concept of a genetic risk for suicide, but it turned out that it wasn't heard that way by the participants, so we didn't get the information that we really wanted there. We also asked, would people want to know this information about themselves or about family members, especially children? If they had what we were calling a positive test, how would that impact them or their family? If they had a negative test, how would that impact them or their family? I should note that we had a lot of debate about how to phrase this question and ultimately settled on a positive versus a negative result for the sake of simplicity, recognizing that polygenic risk scores really aren't positive or negative, but we explain this as essentially meaning a polygenic risk score that showed an increased risk of suicide relative to the population as a positive test and a negative test otherwise. And we asked people what they would see as the potential benefits and risk of getting that information for themselves or for family members. So again, with question 1, we didn't quite get the answers that we wanted since we were trying to go at a conceptual question. Some people raised a sense of confusion about the possibility of a genetic test for suicide. It was hard for them to imagine that you could have a genetic risk for something that was simply a behavior. Others were sort of positive about the possibility. They thought that if there was a genetic test for suicide, or they were found to have a genetic risk for suicide, it would give them a sense of greater self-compassion, because they would be able to think that their suicidal ideation, their tendency to suicide, was out of their control. Others thought that it would conduce to better treatment or prevention, that they would be able to do things now that would mitigate their risk of suicide. And some thought that the genetic test, I thought this was actually pretty on point, wouldn't be terribly useful because they knew that they had a family history of mental illness and suicide, and getting the genetic test wouldn't really tell them anything new. When we asked family members the same question, they had relatively similar responses. Some were confused. How can genes predict behavior? Some, again, thought that it might give more validity to suicidal ideation and related symptoms. It would insist healthcare providers in taking conditions more seriously. It might reduce stigma or discrimination, lead to better treatment or prevention. And again, others thought that it just wouldn't be terribly informative because of what they already know about themselves. When we asked people whether they would want to get this information, and I think this might have been the most important question that we asked, survivors generally tended to say yes, although there were a lot of dissenting votes. Those who said yes thought that it would help with better treatment. It would allow them to be more aware and preventative. Others thought that it would allow others in society to be more educated about mental illness and thereby reduce stigma. Those who said no raised some relatively concerning guesses about how this information would affect them. Some were just thinking that it would cause anxiety. It would be difficult to have that information, and they weren't sure what the effects would actually be. Others thought that knowing that they had an increased genetic risk for suicide, a so-called positive result, probably would have led them to attempt suicide more seriously. And I'll never forget, I was there when this was said. One of the participants said, if I had known this, I would have pulled the trigger. I would have said, I'm done. Family members, when asked whether they would want this information, said relatively similar things, but raised some somewhat novel concerns. Many of our participants were parents, and they were thinking about the impact on their children. They thought that if they had genetic evidence that their child was at a higher risk for suicide, it would encourage them to fight harder to protect their child's mental health. They would work harder to get access to care. Others were worried that knowing about the genetic risk would lead to all kinds of uncertainties and anxieties. Some worried about something that they called themselves a self-fulfilling prophecy, that paying too much attention to suicide risk or knowing that one was at risk would somehow increase the risk over time all by itself. And they suggested that perhaps this isn't something that we really need to know about ourselves. Family members also raised concerns about how this information would affect things like health insurance companies, decisions to issue policies, possibly employment. And I'm not sure whether that was because they weren't aware of the Genetic Information Non-Discrimination Act or simply didn't trust that it would provide adequate protections. I'm going to skip over this for time, go on to question 3. When we asked if you received a positive result, how would that impact you or your family? Our survivor participants again said that it would help them feel more loving towards themselves. It would reduce stigma. It would allow them to communicate to family members and others that this was a vulnerability over which they had no control, and then perhaps they wouldn't be blamed for it as much. They talked again about advocacy and how it would help them with their children. But again, some raised concerns about the psychological adverse effects. Possibly it would lead them to see themselves as a burden, make them isolate themselves from others, and potentially increase their risk of depression and suicide in the long run. Family members, when asked the same question, had similar thoughts. Again, themes of reduced stigma, better understanding, better treatment and prevention, and the idea that knowledge is power. I'm going to skip that for the moment. When we ask people just overall, what would be the potential benefits and risks of knowing this information, many of the participants, I think somewhat strikingly, had views about how this would impact society as a whole, as though the availability of these genetic results would really change policy. They said things like, this information would lead to increases in funding for mental health care, for support services in schools. It would give people on the whole a better vocabulary to talk about suicidal ideation, as though validation of the genetic risks for suicide would make it seem more real and more worthy of attention at a social level. Similarly, family members thought that having genetic tests for suicide risk would potentially lead to expanded insurance benefits, increased funding for mental health programs through policy changes, and even, I thought rather optimistically, improved gun safety, reduced mass shootings, reduced gun sales across the country. I thought, if only, that would be amazing. So in the last couple of minutes, I just want to talk a little bit about some of the concerns that we have raised, largely informed by these focus groups. In a recent article that Dr. Doherty and others here at the university published with me, and also many of these are raised by Brian Mishra and David Weistub in a recent article about the same topic. I think there are many concerns one could have about doing direct-to-consumer genetic testing for suicide risk, but probably the biggest one is just the limited predictive accuracy of these kinds of tests. There are problems on the input side. There is, I think, still huge uncertainty in phenotyping people post-mortem. It's not always clear that someone died of suicide, even if the evidence is suggestive. Suicide is still, fortunately, a relatively rare phenotype. There's also probably a lot of variation in the how and the why of suicide across many demographic factors, across the lifespan, across persons of different races, across different cultures, probably even across historical era. You might wonder, are people who are dying of suicide now during the pandemic and because of the pandemic the same as the people who would have died if we hadn't had the pandemic? My guess is that they're not, or at least not entirely, because people are going to respond differently to different stressors, and that's going to change their risk over time. There are also output problems. So supposing one did have a positive result, a result that indicated that one's risk of suicide was increased, what does that really mean? Does it mean that one is currently at risk, or one is simply exhibiting a predisposition that might be triggered in different environments or different circumstances? How do we interpret a predisposition for a rare behavior that is distributed over the lifespan? There are also real concerns about the utility of these tests. So even if a polygenic risk score for suicide was somehow indicative of a real risk for the behavior, it could still be that the most actionable components of that risk in terms of prevention would be mental disorders. So if somebody has a mental disorder and they also have an elevated polygenic risk score for suicide, that would entail that they simply just need to get more mental health treatment. And it's not clear to me as a clinician that that test would change what I do clinically, except perhaps a little bit more vigilance about safety planning. If somebody doesn't have an active mental disorder, then it's not really clear what we should do, except perhaps all of the things that people should be doing anyway, irrespective of whether they have one of these tests, things that conduce to overall health and wellness, like not smoking, avoiding alcohol or using it moderately, making sure that they don't have a firearm, or that if they do, it's locked up and kept safe, exercising, sleeping well, maintaining good social supports, participating in their communities, and so on. So I just want to acknowledge all the folks on our team. We had a very interdisciplinary panel of experts. Hillary Kuhn and Anna Doherty are both the geneticists here. Dr. Doherty is also a clinical psychologist. Dr. Botkin, many of you probably know. Leslie Francis is a lawyer or attorney who thinks a lot about the law surrounding disability and genetic testing, as does Tennille Brown. Louisa Stark is an expert in community engagement, conducting focus groups like those we did. And Brooks Keeshan and Doug Gray, like me, are both psychiatrists who think a lot about suicide. So just want to acknowledge those organizations that help support this work, and especially the community engagement team here at the University of Utah, Heather Brown, Brianne Whitty, and Naomi Flake, who really did all the hard work in making this happen. And I think that's my time, so I'm happy to take questions.
Thank you so much, Dr. Kious. So, you know, in planning this session, we plan to have a talk on the science, a talk on the theoretical aspects of the bioethics from a conceptual point of view, which you covered to some degree also. But then our third talk was on, you know, empirical data addressing this topic of polygenic prediction in psychiatry. So we're open for questions or comments. Brandy Fox, you've had your hand raised for some time. Did you want to? Okay.
Sure. Yeah. Thank you. First of all, that was fascinating. I've got kind of a two-part question. It seemed from the quotes that a lot of your people you interviewed equated suicide with mental illness. Did you find them making a differentiation between those different concepts?
It's not something that we asked them about specifically, but I agree. The quotes indicate that there's some conflation of the two. My sense is yes and no. They clearly differentiated certain mental illnesses from suicide, ADHD, or substance use disorders, for example, they didn't think of as necessarily connected to suicide risk. But they did think that somebody who dies of suicide almost always has something like depression going on. That was very clear from the way they talked about how the polygenic risk scores might impact their own thinking and own symptoms and own suicide risk.
Okay. And then the second part, you covered a little bit of it on your utility slide. Given the lack of evidence for most suicide prevention programs, I guess, what did the people expect? I guess, what can we do with this knowledge now?
What can we do? To be honest, don't think that we can do much right now from a public health or mental health standpoint. I don't think that it would be terribly useful to get this information about my patients. I wouldn't want it about myself. I think that it's primarily interesting from a research standpoint, clearly important to identify pathways that produce a higher risk of suicide over time. That's going to be very informative, potentially. And I think it's really important to think about gene-environment interactions when it comes to those pathways. but my guess is that these results really aren't going to translate to things that are clinically actionable for decades. Some of my geneticist colleagues might disagree with me about that. So, you know.
Great, thank you so much.
Thank you.
Dr. Hyman.
Yeah, I mean, I'm not actually a geneticist. I'm a consumer of genetics, but I don't disagree. In fact, I think that the whole field with suicide as a behavior is vastly underpowered for reasons you've touched on. It's if completed suicide is a different phenotype than some of the other suicide-associated phenotypes. We have almost no power to do genetics because it's as common as it is and tragic as it is, it's still a rare behavior. But what I was going to say is, and this is difficult in the United States, and it's very much apart from genetics, but you did mention safety, right, as one response. There have been population level interventions. Perhaps the most effective one is in China, removing organophosphate insecticides from farms, where very distressed women typically were committing suicide using them. It was the only country, I think the only country, but one of the only where there were more completed suicides among women than men. And this was addressed by the general director of the World Health Organization, Group Brundtland, who was interested, not that this matters completely, but because her son, who had bipolar disorder, committed suicide. Well, so organophosphates, it was like taking guns out, right? I mean, organophosphates were removed from all these farms and sheds, and the suicide rate went way down, especially among women. And one wonders about taking, and then again, it's not realistic. I understand politically in the United States, especially in the West, but you know, what I'm thinking is that these interventions take political will, and genetics doesn't help you one way or the other. I don't know if you have as a clinician, I mean, I guess you have to work with what is possible in the state in which you practice.
Mm-hmm. Well, yeah, so I think your example of a successful intervention is a good one. I think that's true in China as well as in India. Mm-hmm. I also want to say that there's some evidence that that policies that reduce the availability of acetaminophen, or what they call in the UK paracetamol, have reduced suicide deaths. In the US, you can buy 1,000 tablets at Costco, right? And it doesn't take that many to overdose. And in the UK, you have to punch them out of a bubble pack,
right?
And we could do that here, and it probably wouldn't be too politically hard, although everything seems politically hard these days. You know, I guess I may be a little bit more optimistic about the politics. Maybe some of my our study participants were actually right, that if there was clear evidence of a genetic risk for suicide in ways that aren't fully rational, that would persuade policymakers, politicians, that this is something we need to take a little bit more seriously. You know, I don't quite understand the human mind well enough to know whether that would be effective, even though I'm a psychiatrist. But I think it would be worth trying at least.
Thanks.
Thank you.
Catherine Ehring.
Hi, thank you for the talk. I have a quick question about some of the pedigrees that you showed sort of early on in the talk, right? If I'm remembering right, it seems like there's a certain generation, or at least for the 2 pedigrees, where you start to see more incidents, right? Or more suicides or attempts or something. And I'm wondering if that observation is true. And if so, does it suggest more of an environmental or change in community structure? I guess you had it on one of your conclusion slides about other factors that might increase risk, but I'm just wondering how you think that that might interact with genetic risk, or I guess other insights about this sort of environmental component to it.
So I guess I would say I personally believe, and I think there's pretty compelling evidence that lack of community structure, lack of a sense of meaning and purpose in one's life all of the malaises associated with modernity make suicide risk worse. I don't think the pedigrees necessarily suggest that, largely because the appearance of lots of suicide deaths in the later generations is an artifact of the data. So some of the progenitors of those pedigrees were here in the 1850s, and we have no idea how they died. It could have been from suicide. It could have been from other causes.
Thank you.
Thank you.
I was curious about something. You spoke about trying to simplify the discussion by using positive genetic tests and negative genetic tests. We often worry that the word positive implies good and negative implies bad, which is the opposite of what you mean to imply when you're talking about a positive or negative genetic test. I wonder if that might have introduced any lack of understanding among the people in your groups.
I could certainly see that happening, that it was confusing, although I didn't have the sense that people didn't understand what the result meant, right? When they talked about a positive test, and that seemed a phrase they were comfortable using, they clearly meant a test that indicated an increased risk of suicide, increased genetic risk.
Yeah.
It could be that apart from potentially confusing them, biased their assessment, right? Maybe just the word positive made them feel a little bit more positive about the information than they would have otherwise. Feels to me like something we could get at with future studies, and so something for me to kind of make a note of.
Another thing that I thought about was, in the early stage of research, we always ask people, would you want testing if it were offered? But the problem with that is that when push comes to shove, oftentimes, if a test were developed, the uptake is very low. I've seen this in my own research where like 80 to 90% of people said they would want genetic testing for epilepsy if it were offered. But then when we actually offered it, it was like very, very low, like, I don't know, 20% uptake. So, that's just an interesting point as well.
Yeah, I think that's really interesting. And I wonder whether that would ultimately apply for suicide, if only because it seems to be a phenotype that people care a lot about right now and is on our mind a lot. So if it were commercially available as a standalone test, maybe more people would opt for it. But the reality is that if you get your gene sequence through, your genome sequence through 23andMe, and you send it off to Genomewide or another company to have your polygenic risk scores calculated, you'll get the suicide risk result if they're offering it, whether you want that specifically or not. And people do, as I'm sure all of you are aware, really have a lot of interest in getting those kinds of general health reports. So that's probably, in my view, the bigger concern, that this is going to be something that is inflicted upon people, often without them really wanting it in the first place. And then they've got this information they didn't really ask for.
Yeah, and your summary of all the places where it is actually available was quite alarming and eye-opening. It actually opens the possibility of doing research on people who have received those results. Are you planning to do that?
We have talked with colleagues who are trying to conduct studies that assess the effects of these tests on people who got them for general mental health conditions, and they have had a really hard time recruiting. So we have not taken a lot of steps towards this yet, but I think it's something we're very interested in doing over time.
Yeah, Dr. DeVries, who just spoke before you, summarized some studies that are actually in the chat. You can look in the chat and see there are a few studies that have done that with polygenic risk scores, looked at people who received them and looked at their reactions.
Yeah, that's actually really interesting to me. I was glad to see that reference.
Oh, yeah, yeah.